Welcome to the Hospital Medicine Unplugged podcast.
Glad to be here.
Our mission today isn't just to review guidelines, but to really do a critical deep dive into diagnosing and managing unintentional weight loss, or UWL, and malnutrition in the hospital.
Right.
We're focusing on how we can standardize our approach using solid, evidence-based frameworks to guide what we do for our most vulnerable patients.
And we have to start by highlighting the stakes here, because this is a massive institutional problem that, frankly, often flies under the radar.
It really does.
Malnutrition is rampant. We're talking anywhere from 20 to 50% of hospitalized older adults, and the consequences are, they're far from benign.
Not at all.
It's strongly linked to increased morbidity, mortality, sometimes for up to 6 months after they leave the hospital, and also significant functional decline, and of course, longer hospital stays.
And that's often independent of why they were admitted in the first place, right?
Exactly. It becomes its own independent problem.
That prevalence is staggering.
Wow.
It really points to a major quality gap in hospital medicine. It's common, it's dangerous, and we often fail to recognize it or, address it systematically. So the bedrock of our approach today is going to be the Global Leadership Initiative on Malnutrition, or GLM criteria.
Right, the GLIM criteria. It's the standardized two-step framework that brings together screening, objective phenotypic criteria, and the underlying etiologic factors.
And the central challenge, the thing that I think trips us all up, especially in acute care, where patients are so volume unstable.
The fluid.
The fluid, it's distinguishing true nutritional weight loss, so loss of muscle and fat, from just weight changes because of disease, inflammation, or, like you said, fluid shifts.
And if we can't reliably separate muscle loss from water weight, our nutritional therapy is just fundamentally flawed from the start. This differentiation is the absolute pivot point.
Okay, let's unpack this. We have to start with the language. What are the formal thresholds? What defines clinically significant unintentional weight loss when we're taking a history?
So UWL is defined as weight loss that happens without someone trying to lose weight. The clinically significant thresholds are pretty specific, and they depend on the time frame.
Good.
We look for a greater than 5% loss in the past 3 to 6 months, or greater than 10% loss over longer periods, so usually beyond 6 months.
That's helpful, but I've heard those numbers have to be adjusted in patients who are, already underweight or frail. Is there a different standard for them?
Yes, that's a really essential clinical detail. For patients who already have a low body mass index, or showing signs of frailty, a loss of just greater than 2% can be considered clinically significant.
Even over a short time?
Even over a short time, they just have less reserve to lose. And to be specific, within the GLM framework, the weight loss criterion they use as a key phenotypic marker is strictly defined as greater than 5% within 6 months, or greater than 10% beyond 6 months.
Got it. So moving from the definition to the causes, when we start the diagnostic hunt for UWL, what are the most common things that pop up?
Well, if you look across all demographics, the data is pretty consistent. The most common primary causes are malignancy, non-malignant GI disease, and psychiatric conditions like depression.
And does that pattern change when we focus on older adults? Because that's most of who we see in the hospital.
It shifts slightly. In older adults, non-malignant diseases are actually more common overall than malignancy. And this is but malignancy still accounts for a disproportionately high rate. We're talking up to 1/3 of all cases.
1/3 is substantial. That really underscores why a structured cancer screening workup is just non-negotiable.
It is.
But here's the crucial caveat. We don't always find a neat answer. How often does the workup just yield nothing definitive?
And that's the clinical reality we have to be ready for. Despite a really comprehensive standardized evaluation, a clear primary cause for the UWL is just not found in a significant minority, somewhere between 6 and 28% of cases.
That's a huge range.
It is. And that uncertainty can't lead to complacency. It means that even when the initial workup is negative, we have to have a standardized follow-up plan. We can't just label it idiopathic weight loss and send the patient out the door without a safety net.
That sets the stage perfectly for the diagnostic hunt. But before we get into the nuts and bolts of the workup, we have to understand the engine driving this. UWL isn't just about not eating enough.
Not at all.
It involves these complex two-way signaling pathways that just accelerate the decline. Can you walk us through those two interconnected biological pathways?
Certainly. Unintentional weight loss is really a self-perpetuating vicious cycle.
Right.
It's driven by two main mechanisms that are almost always operating at the same time.
Okay.
The first one is obvious, nutrient deprivation. That comes from reduced food intake or malabsorption. The patient just isn't getting enough fuel.
Simple enough.
But the second pathway, and this is often the more dangerous one in the acute setting, is inflammation-driven catabolism. This actively accelerates tissue breakdown, especially lean muscle mass.
Let's focus on that catabolism side, because this is where the acute phase response essentially overrides the body's normal adaptive mechanisms for starvation, right?
Precisely. In normal starvation, the body tries to spare muscle by switching over to fat stores. Inflammation completely disrupts this.
How so?
Well, acute or chronic inflammation is the key driver. The main orchestrators are pro-inflammatory cytokines, interleukin-6, interleukin-1 beta, and tumor necrosis factor alpha.
The usual suspects.
Exactly. These cytokines are basically signaling molecules telling the body to break itself down. They delay gastric emptying, which leads to early satiety. They directly suppress appetite by acting on brain circuits, and critically, they directly stimulate skeletal muscle catabolism.
And how does that muscle wasting actually happen at the cellular level, especially in our critically ill patients where we see it happen so fast?
In critical illness, the metabolic response shifts completely away from preservation. The stress hormone axis, so cortisol and catecholamines, gets activated, and that dramatically increases protein breakdown. This inflammatory and hormonal signaling hijacks the cellular machinery. Specifically, it drives excessive protein breakdown by overactivating the ubiquitin proteasome pathway.
Okay, let's unpack that term for a moment, the ubiquitin proteasome pathway. In simple terms, what's happening there?
You can think of it as the cell's sophisticated shredder or recycling plant. Ubiquitin is a tag that marks proteins for destruction, and the proteasome complex is the machine that rapidly dismantles them into amino acids.
So it's a targeted process.
Very. But when the body is inflamed, that cytokine storm just ramps up the efficiency and volume of this process in skeletal muscle. So we are actively and rapidly destroying functional muscle tissue to create amino acids for other acute needs, like the immune response or wound repair.
And this happens quickly.
Alarmingly fast. We often see this within the first week of critical illness, and the rate of muscle wasting is really proportional to how sick the patient is.
So while the body is aggressively shredding its own muscle, reduced intake is simultaneously starving it of any replacement parts.
Exactly.
How does inflammation chemically suppress appetite?
It directly acts on neural circuits in the hypothalamus. But beyond that, the disease symptoms themselves are a huge barrier. Think about dysphagia, persistent nausea, vomiting, or just general GI dysfunction.
And there's a hormonal component too.
Yes. There's an accumulation of certain appetite-inhibiting hormones. Things like cholecystokinin, GLP-1, and leptin, which normally signal that you're full after a meal, they accumulate and contribute to this persistent anorexia, even when the stomach is empty.
And when we layer aging on top of this, are there unique factors in older adults that make them so susceptible?
Absolutely. The older adult body is fundamentally primed for this decline. One key concept is inflammaging.
Inflammaging.
Right. It refers to a chronic, low-grade sterile inflammation that's just associated with the aging process itself. This low-grade inflammation modulates appetite, it dulls taste perception, and it negatively affects protein metabolism. It basically sets a lower threshold for severe catabolism when an acute illness hits.
And that's coupled with other physiological changes.
Yes. Things like reduced sensory function, so diminished taste and smell, and endocrine changes like decreased levels of acylated ghrelin, which is the main appetite-stimulating hormone. All of these factors make older adults highly vulnerable.
Finally, we have to acknowledge the factors that we introduce in the hospital. What are the hospital-specific barriers that can turn an at-risk patient into a malnourished one?
There are so many, and many are modifiable. Polypharmacy is huge. A lot of essential medications interfere with taste, cause dry mouth, or induce nausea, making food just completely unappealing. Immobilization, even for a few days, leads to rapid disuse-related muscle wasting. And then you have the operational things. Repeated, often unnecessary fasting orders for tests, suboptimal hospital food quality, and just generalized concerns about aspiration that lead to overly cautious diet restrictions.
It's a perfect storm.
All of these systemic factors create huge barriers to getting adequate nutrition. It reinforces that dangerous, vicious cycle where the hospitalization itself increases the risk.
That deep dive into the pathophysiology is so important because it validates the systematic approach we need to take. So let's move to the core diagnostic process, screening and the GLIM framework.
The first critical step is nutritional screening, and the timing here is absolutely non-negotiable. Screening has to happen universally within the first 24 to 48 hours of admission.
And you have to use a validated tool.
A validated tool, yes. And the goal here isn't to diagnose malnutrition, but to identify patients who are at risk and therefore need that full, more time-intensive diagnostic assessment from a dietitian or physician.
So what are the primary validated tools we should be considering for the general hospitalized adult population?
There are several recommended by major nutrition societies. These include the Nutritional Risk Screening 2002, or NRS 2002, the Malnutrition Universal Screening Tool, or MUST, the Short Nutritional Assessment Questionnaire, SNUA, and the Malnutrition Screening Tool, or MST.
With so many options, is there one that kind of stands out for accuracy or utility?
Yeah. The MUST tool has shown some really impressive accuracy in meta-analyses. It often has the highest sensitivity, around 73.6%, and an overall accuracy of about 86.8% in some populations.
And it's practical to use.
It's concise, easy to implement, and its score is an independent predictor of worse outcomes. But it's important to remember the context. For older adults, which is our focus, we should really highlight the Mini Nutritional Assessment Short Form, or MNA-SF.
Because it's specifically validated for that group.
Exactly. It's adapted for that vulnerable, often frail demographic.
Okay, so once screening flags a patient as at risk, we move to step 2, the formal diagnostic assessment using the GLIM criteria. Can you just reiterate the fundamental requirement for formal diagnosis under GLIM?
The GLIM framework demands synergy. To formally diagnose malnutrition, the patient has to meet at least one phenotypic criterion and at least one etiologic criterion.
Yes.
You need both. You need objective evidence of the weight or muscle loss, and you need evidence of the driver, the reason why it happened. If you only have one, the diagnosis is incomplete.
Okay, so let's review those measurable components. What are the phenotypic criteria?
There are 3, and they represent the physical signs of decline. First is unintentional weight loss, using those specific GLIM thresholds we talked about, greater than 5% loss in less than 6 months, or greater than 10% in more than 6 months.
Okay.
Second is a low body mass index, and this has age-specific cutoffs, less than 20 if the patient is under 70, or a higher threshold of less than 22 if they're 70 or older.
And the third?
The third is reduced muscle mass, which needs an objective assessment, usually through imaging, anthropometrics, or functional tests.
Why the higher BMI cutoff for older adults? Is that just recognizing they tolerate less weight loss?
It reflects the fact that lean mass loss is just far more detrimental in older adults. The higher threshold of 22 acknowledges that even a mildly lower BMI in this population often correlates with underlying sarcopenia muscle wasting and a significantly reduced functional reserve. It's an attempt to catch it earlier.
That makes sense. And what about the etiologic criteria, the drivers?
These are the underlying factors causing the decline. First is reduced food intake or assimilation, so a primary lack of nutrients reaching the body. This could be due to anorexia, dysphagia, or malabsorption.
And second?
The second is inflammation or disease burden. This is indicated clinically by an acute or chronic illness and supported by elevated inflammatory markers like CRP and ESR.
The GLM framework also lets us grade severity, which is so important for prognosis. How is severity determined?
Severity is graded entirely based on the degree of that phenotypic abnormality. We classify it as stage 1, which is moderate malnutrition, or stage 2, which is severe.
And what would qualify as stage 2 severe?
For example, stage 2 malnutrition is indicated by a severe reduction in muscle mass, or by extreme weight loss, so greater than 10% loss in less than 6 months, or greater than 20% in more than 6 months. This stratification is crucial because GLIM diagnosed malnutrition, especially stage 2, is associated with a significantly increased risk of adverse outcomes.
Now we get to perhaps the biggest diagnostic hurdle we face in the hospital, the fluid conundrum. How do we distinguish true unintentional weight loss of muscle and fat from just volume status changes? This is a constant battle on cardiology and nephrology services.
This is a critical distinction that often completely misleads clinicians, especially with patients coming in with heart failure exacerbations, AKI, or advanced liver disease.
Right.
Fluid shifts, whether it's peripheral edema, ascites, or even acute dehydration, can dramatically mask true nutritional weight loss or mimic it. Standard weight measurements simply cannot reliably differentiate between loss of lean tissue and fluctuations in total body water.
I remember some striking data on this. Can you share that insight about how profoundly fluid status affects measured weight?
The data fundamentally flips how we should prioritize our physical exam. There was a notable study of older men in transitional care, and 70% had lower extremity edema. In that cohort, the change in maximal calf circumference, which is an objective proxy for edema, was the strongest predictor of measured weight change. It had a partial R-squared value of 0.35.
And how did that compare to actual food intake?
Well, that's the kicker. Actual nutrient intake only contributed an R-squared of 0.14.
Wait, so edema accounted for more than twice the measured weight change than actual food intake?
Exactly. It emphasizes that in the acute setting, weight change is dominated by volume status and should be interpreted with extreme suspicion.
That is the mind flip moment we need. It means the scale often lies to us in the acute setting. So how should clinicians assess this? What strategies help us separate water from muscle?
We need serial measurements and ideally objective body composition analysis when we can get it. The basic approach is using serial measurements of both weight and calf circumference, combined with a meticulous physical exam.
Looking for what specifically?
You're looking for signs of muscle wasting, temporal wasting, prominent clavicles, deep interosseous spaces in the hand, and of course the presence and extent of edema. If the patient's weight is stable but their calf circumference is going down, they are likely losing muscle and gaining fluid.
Let's talk about labs, which are notoriously over-relied upon. Why are traditional serum biomarkers so unreliable for assessing nutritional status in acutely ill patients?
This is a massive pitfall. Traditional visceral protein markers like albumin, prealbumin, or transthyretin transferrin, and retinol-binding protein are all negative acute phase proteins.
Meaning they go down with inflammation?
Precisely. When a patient is acutely ill or inflamed, these protein levels fall precipitously. And it's not because they suddenly stopped eating. It's because of increased vascular permeability, a shift in liver synthesis, and fluid shifts that dilute everything.
So what do they reflect, if not nutrition?
They reflect the inflammatory and prognostic status of the patient. They are prognostic markers, not diagnostic tools for malnutrition.
So if those traditional markers are out, what should our first-line lab evaluation include to investigate the underlying causes of the UWL?
The initial workup needs to be broad, targeting reversible and common causes. So a complete blood count, a basic metabolic panel, and liver function tests. We have to check thyroid function with an ultrasensitive TSH.
And inflammatory markers.
Yes. Get a CRP and an ESR to gauge the level of inflammation, and an LDH to assess for tissue breakdown. A urinalysis and a glucose check are mandatory. And crucially, we have to make sure age-appropriate cancer screenings are up to date.
Beyond labs, what's the required first-line imaging, and what about stool studies?
The recommended initial imaging is pretty basic. A chest radiography and fecal occult blood testing. Abdominal ultrasound or CT should be considered early based on the history and initial findings, especially if you're worried about malignancy.
And stool studies.
Targeted stool studies are only necessary if there are overt GI symptoms like bloody diarrhea or steatorrhea. Then you'd order culture, O&P, and a Clostridioids difficile toxin assay.
Okay, that covers the initial sweep. If that workup is negative, we move into more targeted second-line testing. Let's start with the GI workup.
If the symptoms strongly suggest a GI, etiology, persistent dysphagia, nausea, unexplained bleeding, endoscopy is the next step.
Both upper and lower.
Both upper GI endoscopy and colonoscopy are considered second line. We know they have a reasonable diagnostic yield in carefully selected patients.
And for specific malabsorption syndromes, what tests are high yield?
If you suspect malabsorption, chronic diarrhea, bloating, steatorrhea, we need specialized tests. A key test that's often overlooked is fecal elastase.
For pancreatic insufficiency.
Exactly, for pancreatic exocrine insufficiency, or EPI. We also need tissue transglutaminase antibodies for celiac disease and specific vitamin levels like B12, folate, and the fat-soluble vitamins.
Malignancy is the big scary one, accounting for up to 38% of cases. What are the key clinical predictors that should really raise our suspicion for cancer?
We have to be alert for a cluster of high-risk predictors. These include age over 50, a smoking history, unexplained anemia, an elevated alkaline phosphatase, elevated LDH, a low serum albumin, and a high or low white blood cell count. The more of these a patient has, the more aggressive we need to be.
Imaging is critical here. How accurate is something like a CT scan? And can we use it for more than just looking for a mass?
Whole body CT has good diagnostic accuracy with a sensitivity around 72% and a diagnostic yield of about 33.5%. But critically, we can leverage this for more than just diagnostics.
So.
A CT scan, particularly looking at a cross-section at the third lumbar vertebrae, the L3 level, can be used to objectively assess body composition and muscle mass. This directly feeds into that reduced muscle mass criterion for GLIM. It becomes a valuable two-in-one tool.
We often see tumor markers ordered reflexively. Should we be relying on CEA, PSA, or CA19-9 for screening UWL?
I would advise caution. The routine use of these markers as primary screening tools is generally discouraged. Their yield is limited, and they have a significant risk of false positives, which can lead to unnecessary, invasive, and anxiety-provoking workups.
So save them for when suspicion is already high.
Right. They're best used when you already have a strong suspicion for a specific cancer type or for monitoring recurrence, not for broad screening.
Now, for that significant group of patients where the initial comprehensive workup is unremarkable, what's the right follow-up strategy?
The clinical instinct might be to just keep ordering more and more tests, but the data suggests restraint is better. For these patients, the recommendation is a dedicated 3 to 6 month observation period with regular follow-up appointments.
Why that approach?
It allows time for more subtle diseases to declare themselves, and it balances diagnostic thoroughness with resource utilization. It avoids immediate, low-yield invasive testing.
That leads us perfectly into the causes that are frequently overlooked, the diagnostic pitfalls. Let's start with depression, which is so consistently missed.
Depression is often the leading cause of unintentional weight loss, particularly in frail, long-term care residents. And the crucial pitfall is that in older adults, depression often presents atypically.
They don't just say, "I'm sad."
Exactly. They may not complain of sadness at all. Instead, it manifests as neurovegetative symptoms: fatigue, insomnia, pervasive anorexia, and weight loss, often without those prominent mood symptoms we expect in younger patients.
So if the mood symptoms aren't prominent, how do we reliably catch it?
We have to formally screen. We need to use validated tools like the Geriatric Depression Scale or the PHQ-9. Failing to probe for these accompanying depressive symptoms is one of the most common reasons for underdiagnosis.
Another factor we touched on is polypharmacy. We know medications cause issues, but how extensive is this problem of drug-induced anorexia and weight loss?
A medication review is absolutely essential. It's a major but highly correctable pitfall. We know that over 200 medications can induce taste disorders or dysgeusia, which directly compromises intake.
And it's more than just side effects like nausea.
Much more. Many common anticholinergic medications cause severe dry mouth, xerostomia, which severely impairs the ability to chew, taste, and swallow, and we have to be vigilant about avoiding certain high-risk meds like Magestrol, which has no good evidence and serious adverse effects.
What are the key endocrine pitfalls we need to actively rule out?
There are two primary areas. First, we have to follow up on any abnormal ultrasensitive TSH, since both hypo and hyperthyroidism are common reversible causes. Second, we have to evaluate for adrenal insufficiency.
The great mimicker.
It really is. It presents with such nonspecific symptoms, fatigue, anorexia, weight loss, hypotension, that overlap with acute illness or depression. It's frequently overlooked, especially in patients who have recently been acutely ill or tapered off glucocorticoids.
And how do we work that up?
If you suspect it, the initial workup requires an early morning serum cortisol and ACTH. If those are low, that's a signal. The definitive diagnostic step is the ACTH stimulation test, which assesses the adrenal gland's maximal reserve.
Moving on to special populations, let's revisit the needs of older adults. You mentioned the adjusted GLM thresholds for them.
Yes, the BMI threshold is less than 22 if the patient is 70 or older. It's a higher threshold, recognizing that even a small amount of lean mass loss is more detrimental in this population.
And what are the high-yield diagnoses we often miss in this specific demographic?
We have to look beyond the standard malignancy workup. Oral disorders, dry mouth, poor dentition, ill-fitting dentures rank second only to non-hematologic malignancy as a cause of weight loss in patients over 65.
Second only to cancer. That's huge.
It is. And depression, as we discussed, is the other frequent miss. The assessment has to prioritize these functional aspects, evaluating dentition, swallowing, and modifying contributing medications.
Let's address patients with chronic organ failure, renal, cardiac, or hepatic. They represent a unique challenge because of the constant volume shifts.
These patients are the most difficult. They're prone to severe fluid overload, peripheral edema, and ascites, which effectively masks protein energy wasting. They might be losing muscle rapidly, but their weight on the scale is stable or even increasing.
So relying on serial weights is clearly insufficient here.
Yeah.
What techniques are required for an accurate assessment in these populations?
We absolutely need more sophisticated objective tools. Body composition analysis is essential. That includes methods like bioelectrical impedance analysis, DXA, or, most practically in the hospital, using CT imaging at that L3 level. Serial measurements of weight and calf circumference are still necessary, but they have to be interpreted in light of the patient's volume status.
Finally, let's address oncology patients and the specific syndrome of cancer cachexia. How is this different from simple starvation?
Cancer cachexia is a distinct and devastating syndrome. It's not just simple anorexia. It involves physical wasting and muscle and visceral mass loss that often occurs independent of appetite or caloric intake.
So it's an active process.
It's a fundamentally inflammation-driven catabolic state. The tumor and the body's response to it generate a persistent cytokine signal that just drives muscle breakdown.
And what's the clinical implication? Why is recognizing cachexia so crucial?
It conveys a very poor prognosis, and it severely limits treatment options. It's associated with increased treatment toxicity, delayed or terminated chemo, and profoundly shorter survival. Critically, muscle depletion in cancer patients conveys a poor prognosis regardless of their BMI.
So we have to look for that underlying sarcopenia.
You have to, which brings us back to the importance of objective body composition assessment across all of these populations, especially where fluid is confounding the picture.
Right. So to confirm that reduced muscle mass criterion for GLM, what are the best available methods?
We have to get past the weight scale. We rely on advanced imaging and specialized anthropometrics. So that's bioelectrical impedance analysis, BIA, DXA, detailed CT imaging at the L3 level to quantify muscle, and even specialized ultrasound of skeletal muscle thickness. These provide the objective evidence of lean mass loss that we need.
We've covered the framework, the workup, and special populations. Now let's synthesize how this comes together, focusing on the system failures and pitfalls that continue to lead to misdiagnoses.
One major pitfall, as we've discussed, is the failure to critically distinguish fluid shifts from true tissue loss. Clinicians can entirely miss severe malnutrition in a patient with profound ascites or edema.
It can go the other way.
Or, conversely, they might inappropriately diagnose severe malnutrition based on weight loss that is purely from diuresis. The fact that calf circumference change, an edema marker, was the strongest predictor of weight change in research just underscores the need to physically examine the patient for objective signs of wasting, no matter what the scale says.
And we need to be extremely vigilant about overlooking medication effects. Beyond just the Beers criteria, what are the practical implications?
Well, polypharmacy significantly increases the risk, and the impact is often mechanical. For example, being on more than 3 medications daily increases the risk of dry mouth, xerostomia, by nearly 3-fold.
And dry mouth isn't just an annoyance.
It severely impairs nutritional intake. It leads to dysgeusia and difficulties with chewing and swallowing. A meticulous medication reconciliation is non-negotiable, focusing on simplifying regimens and eliminating drugs with known GI side effects.
You also highlighted oral health, which is far too often a cursory part of the physical exam in the hospital.
Absolutely. We said it before, oral disorders rank second only to non-hematologic malignancies as a cause of weight loss in older adults. Dry mouth affects 1/4 of the global population and puts people at high risk for oral candidiasis, dysphagia, and dental caries, all direct contributors to reduced intake. We need a detailed oral and dental history.
Checking denture fit, looking for lesions.
Right. The food doesn't feel right. The patient is just not going to eat.
Let's delve deeper into those frequently missed psychiatric and endocrine causes. We need to formalize the screening process for depression, given its atypical presentation.
Since depression is such a leading cause, formal screening has to be standard practice. Because it presents atypically in older adults, just asking, "Are you depressed?" is not enough. We have to integrate validated tools like the Geriatric Depression Scale or the PHQ-9 into the admission process for at-risk patients.
And regarding adrenal insufficiency, how should we initiate that workup when suspicion is raised?
Adrenal insufficiency is the great mimicker, as we said. If we suspect it, especially after a recent glucocorticoid taper, the initial workup needs those early morning cortisol and ACTH levels. If they're abnormal, you need dynamic testing, the ACTH stimulation test, to assess the functional reserve of the adrenal axis.
Another key GI disorder that often flies under the radar is pancreatic exocrine insufficiency, or EPI. Why is it so challenging to diagnose in the hospital?
EPI is tough because it features stutteria, weight loss, bloating overlap so much with more common things like celiac disease or IBD, it's often just not considered. If a patient is showing signs of malabsorption, we need to specifically order fecal elastase to assess pancreatic function.
The diagnosis and management of these complex cases really demands an interdisciplinary approach. What's the essential role of the nutrition specialist or dietitian?
The nutrition specialist is foundational. They have to be involved immediately after a positive screen. They're the experts in interpreting body composition analysis, taking detailed dietary histories, and most importantly, calculating individualized energy and protein requirements. They are vital for developing the nutrition care plan.
And what are the general caloric and protein goals we should be aiming for once malnutrition is confirmed?
It has to be individualized, of course, but general requirements typically range from 20 to 30 kilocalories per kilogram per day and a robust zero point 0.8 to 1.5 grams of protein per kilogram per day. That protein target is crucial, especially in inflammatory states, to try and counteract muscle loss.
And what specific role does a gastroenterology consult play in refractory UWL?
Gastroenterology is necessary for the advanced diagnostic steps, so doing the endoscopic evaluations, getting tissue biopsies, and managing chronic GI conditions. They also handle the specific testing for malabsorption, like the fecal elastase for EPI, and evaluating for suspected malignancy, like pancreatic cancer.
And the behavioral health team.
Critical. If psychiatric or cognitive causes are suspected, they use formal instruments to differentiate primary psychiatric illness from medical causes of mood changes. And they can assess for cognitive impairment, like advanced dementia, that can lead to nutritional decline because the patient literally forgets to eat.
Finally, where does endocrinology fit into this puzzle?
Endocrinology ensures we capture those metabolic drivers. They interpret complex hormonal testing, manage thyroid and diabetes interactions, and oversee the diagnosis and long-term management of adrenal insufficiency.
We spent a lot of time on the patient factors and disease mechanisms. But the final, and perhaps most critical point, has to be the role of systemic change in the hospital environment itself. We're often part of the problem.
That is the necessary proactive perspective that drives quality improvement. The prevalence of malnutrition is high, but so many hospital-based factors are modifiable contributors. We have to look at our own processes.
Like what?
Medical-related mealtime interruptions, the nurse coming in for a dressing change, the resident rounding, PT coming by, these are massive barriers. Unnecessary fasting orders for non-urgent studies have to be curtailed. Suboptimal food quality and poor coordination of meal delivery are all contextual factors that actively hurt patient intake.
So if we really want to address the high morbidity and mortality associated with this, the focus has to shift beyond just ordering supplements.
Absolutely. The focus must be on addressing these systemic contextual issues. We need hospital-wide policies that enforce protected meal times, reduce unnecessary NPO orders, ensure timely nutrition consults, and improve patient satisfaction with meals. Until we treat the hospital environment itself as a risk factor and modify these systemic factors, we're going to keep seeing these poor outcomes, despite our best efforts treating the underlying disease.
The system has to support the patient's ability to eat. That's a critical call for a systemic audit of our own practices. The GLM criteria gives us the map, but changing the environment is the ultimate intervention.